Right. Well, thank you, Bob. Thanks for hanging in till the last talk of the evening. Very, very impressed that you're still with us. The other thing you'll notice in the last talk of the evening, I might go quickly through some of the slides because you've seen them all before, or you've seen some of them before. But anyhow, it's a slightly different topic, so hopefully we'll impart some slightly different information. So I'm going to be talking about the hormonal management of NETs. So really what I'm going to be talking about is the endocrine in neuroendocrine tumors. You've had a lot of great talks about the treatment of tumors themselves, surgery, chemotherapy, other drug therapies for the tumors themselves, focusing on the size of the tumor, etc. Now we're going to talk about the hormones that come from NETs and what they can do to you, and indeed some of the hormones that are used in treatment of NETs. So I am going to start off with a few definitions because, as I mentioned earlier, the medical profession is full of terms that sound alike but are different, and that sound different but are alike in their meanings. So I just want to make sure that we're all on the reasonably same page there. I'm going to talk about which of the NETs produce which of the hormones, because the hormones that come from different NETs, whether we're talking about lung NETs or bowel NETs or particularly pancreatic NETs, can produce a different array of hormones with a different array of complications. We'll talk about what those various hormones can, the sort of symptoms that they can cause. Then we'll talk about how we focus specifically on blocking the hormones. Sometimes that treatment is the same as the treatments that you've heard about already for shrinking the tumors and controlling the tumors. Sometimes it's slightly different. So we'll talk about interventions for all of the hormones together and interventions for specific hormones and specific syndromes. And then just many of the neuroendocrine tumors that come as part of a genetic disorder actually come with multiple other hormonal abnormalities and hormonal tumors that need their own specific therapy. So some definitions. Endocrine, related to any of the related to glands that secrete hormones into the blood. So there are a couple of aspects to that. One is that they make a chemical which we're going to call hormones that they get into the bloodstream. A hormone itself, we tend to hear about hormones in relationship to raging hormones and angry teenagers, and those are not the hormones that I'm going to be talking about today. Those hormones in general will be either testosterone or estrogen. Not going to mention them any further. Because they don't seem to have a lot to do with NETs, frankly. So a hormone is a chemical. It's produced by the gland, the endocrine gland. It gets into the blood, and it causes a symptom or bunch of symptoms. And so examples of hormones might be serotonin, insulin. Now, you'll also have heard of tumor markers. Well, they're things in the blood. So is a tumor marker a hormone? Is a hormone a tumor marker? So a tumor marker or a biomarker is a chemical produced by the cancer cells, or indeed the cells around the cancer cells, that gives us some information about the cancer, whether it's an aggressive cancer, whether it's a cancer that'll respond to therapy X or Y. So one of the tumor markers that you may have heard of is chromogranin A. Some people have this as a blood test as part of their 3-monthly, 6-monthly reviews. If I were to give a person an intravenous infusion of chromogranin A, they would not feel any different because it's not a hormone. It does not have a function in the body. It does not cause any symptoms. However, if I give a person an infusion of insulin, they would feel very different. So hormones and tumor markers, both in the bloodstream, both can be tested by blood tests. They are a little different in that the hormones have a symptom with them. And this brings us to the functional and non-functional neuroendocrine tumors. So here's another of these terminology issues, functional and non-functional, because today we've heard about functional tumors, which are tumors that have hormonal symptoms with them. So the flushing and the diarrhea are hormonal symptoms of carcinoid syndrome and carcinoid tumors. You've also, however, heard about functional imaging. Functional imaging has nothing to do with the hormones. Functional imaging is the PET scans that we use. Frequently, it has something to do with the receptors that I'll mention and that have been mentioned already. But a little bit confusing the two uses of the term functional. So a functional tumor is a hormonally active tumor, but it's also one with symptoms. A non-functional tumor, it either doesn't produce the hormones or it doesn't produce enough of the hormones to cause a symptom. And again, this is really complicated as well, because, doctor, my serotonin is 5 times normal. Do I have a functional tumor? Well, no, because you don't have symptoms. Some people don't have symptoms. And I think this starts historically that we had the terms functional and non-functional before we had the ability to measure serotonin and other things. So it is complicated in that way. Syndrome, we'll talk about syndromes. Syndrome is just a group of symptoms that comes together associated with one type of tumor or with one type of hormone. So we'll talk about carcinoid syndrome, that's the flushing and the diarrhea, the wheezing, et cetera, that occur particularly in relationship to serotonin, but also in other things. So getting back to endocrine system, the endocrine system is the system of glands in your body that produce hormones, and most of these endocrine glands are things that are visible to the naked eye, i.e., visible to the naked eye. If the surgeon opens up your neck, the surgeon will be able to visibly see your thyroid. It's visible to the naked eye on the CT scan. You can see a thyroid gland. You can see a parathyroid. You can see an adrenal. However, you can't actually see the neuroendocrine system or the diffuse neuroendocrine system, because they are a series of microscopic cells that really are present in a lot of different places, whether we're talking about the thyroid or the thymus, the lung, as we've heard about already, through the stomach, through the pancreas, through the small bowel, into the large bowel, rectum, women in the ovaries and cervix, men in the prostate, and some in the skin. So we have these microscopic neuroendocrine cells pretty much anywhere in our body. Still a little unclear in many places what the heck the neuroendocrine cells are doing. We have a good idea that the neuroendocrine cells in the bowel have something to do with the motility of the bowel. If there were no neuroendocrine cells, normal neuroendocrine cells in your bowel would just be this sort of flaccid tube, won't contract. But the neuroendocrine system and some other systems help with that contraction. So we have these cells all over our body. Now, to just give you a sense of what that might look like, because it's sort of 1 in every 100 to 1,000 cells in those places is a neuroendocrine cell. This is a picture of if you had a colonoscopy and the gastroenterologist took a biopsy of your colon, and we stained it for colon cells, which are the blue ones, and we also stained it for serotonin, which is only found in neuroendocrine cells, we would find little cells, little reddish, brownish cells spotted throughout here. And those cells, if you were to look at a single one of those cells and also stain it for serotonin, and the serotonin is this brownish stain, or the brownish dots here, you'd find that so you have these rare serotonin producing cells within the rest of the bowel cells. Again, serotonin cells, by my calculation, about 2,500 cells per inch, so pretty darn small. But those are the things that give rise to the neuroendocrine tumors. And while we could have neuroendocrine tumors pretty much anywhere in the body, and we do, the biggie neuroendocrine tumors that you've heard about already today, the small intestine, the pancreas, the lung, bronchus, the one that Jimmy Buffett had was a very aggressive skin neuroendocrine tumor called Merkel cell tumor, but these tumors are present all over the body. Now there are differences. There's a lot of similarity between neuroendocrine tumors in various different places, but there are differences. And one of the differences that we'll talk about is that different neuroendocrine tumors in different sites make different hormones and chemicals, which can give rise to different symptoms. So different tumors make different hormones. And so what I've mapped out here is I've taken the lung, the pancreas, the small intestine, and actually the large intestine as well, and just written out some of the hormones that can be made in those sites. So the lung, it can make serotonin. It can also make histamine. It can also make a hormone that stimulates the adrenal gland to produce cortisol, ACTH. Ones in the stomach, they make histamine. Also, gastrin comes from the stomach. But in the pancreas, you can probably get the most variance of hormones. And I've written these in the size is a manifestation of how frequent they are. So probably the most frequent hormone producing tumor in the pancreas is a gastrin producing tumor. Then insulin producing tumors, and then we have a group of much more rare, VIP, glucagon, the ACTH tumor, and down there at the end is serotonin producing tumors. Only a couple of % of tumors in the pancreas produce serotonin. Different sort of neuroendocrine tumor on the adrenal gland, pheochromocytoma, can produce norepinephrine. Small intestine, we think of that as a serotonin-producing tumor, prominent serotonin-producing tumor. And I've got rectum and colon down with an empty box. So rectum and colon, they do produce chemicals. They don't seem to be chemicals that give rise to much in the way of symptoms, and therefore, for the most part, they are non-functional tumors. I was taught in medical school never say never, and indeed I've seen a couple of people over a long period of time with a carcinoid syndrome with a rectal tumor, but that's very unusual. So different tumors produce different hormones, and different hormones produce different syndromes. So the lung tumors producing the serotonin, well, if it's serotonin, some of the aspects of carcinoid tumor are evident. With the ACTH, some of the aspects of Cushing's, which I'll explain in a moment, are present. The histamine can produce what's called an atypical carcinoid. So here's another terminology that's sort of funky here, because Dr. Ramirez told you about typical and atypical carcinoids of the lung. There are also references to carcinoid syndrome and atypical carcinoid syndrome. I'll show you an example of that, but it's nothing to do with the typical and atypical pathology that you've heard about in the lung. The pancreatic neuroendocrine tumors, the gastrin produces gastrinoma. So we're in Ohio. Who's from Ohio here? Who's living? Oh, yes. So, I was just thinking that this tumor, the gastrin-producing tumor, which produces a gastrinoma, people, kids in Ohio should be taught about gastrinomas, because gastrinoma is a hugely Ohio thing. Gastrinoma is also called ZE syndrome. ZE stands for Zollinger-Ellison. Both Zollinger, Dr. Zollinger, and Dr. Ellison are both Ohio-born. Dr. Zollinger was the head of surgery for quite a long time at Ohio State. And that is indeed where it was during his time at Ohio State that he described gastrinoma. So it's an Ohio thing. An export from Ohio. So insulin produces insulinoma, VIP produces vipoma, and we'll see some of the symptoms of these in a moment. The ACTH produces Cushing's, the serotonin produces carcinoid, the serotonin from the small bowel, again, carcinoid. So different tumors produce different hormones, produce different syndromes. So we've talked about carcinoid syndrome, and again at this point in the afternoon, and many of you have firsthand knowledge of what carcinoid syndrome is: flushing, diarrhea, wheezing, palpitations, heart valve abnormalities, as we heard about earlier. Many of those symptoms, at least some of those symptoms, related specifically to the serotonin that is found in carcinoid syndrome. The gastrinoma is mainly a stomach ulcer. It's basically a high production of acid in the stomach, causing ulceration, also diarrhea. Insulinoma, insulin, you think of insulin and diabetes. Insulin causes low blood sugar. VIP causes a horrendous form of diarrhea, leading to dehydration. Glucagon causes a number of different things, including high blood sugar, but diarrhea, blood clots, weight loss, skin rash, sore tongue, glucagonoma. Cushing's syndrome, which comes from the ACTH, weight gain, bruising, weakness of the muscles, big stretch marks, high blood sugars, and high blood pressure. Pheochromocytoma, producing adrenaline, produces sort of adrenaline rushes and very high blood pressure. Flushing and atypical flush. So this is, again, I hesitate to explain to a group of people, many of whom have personal knowledge of how a flush goes. I hesitate to explain from the outside what a flush is. But flushing, usually characterized by redness of the face, maybe the full face, sometimes redness of the neck area, a feeling of hotness, generally not with sweating or not with prominent sweating. In people who truly have very heavy burden of tumor in the liver, they can have full body sweats, they can have beetroot red sweats, they can actually have a sort of a purplish hue just because of how many flushes they've had. In general, a flush will be gone in 5 to 10 minutes. However, there are atypical flushes, and these atypical flushes, they're seen in relationship to histamine release. And so it's a flush. It may be in the face, but it's sort of geographically around the body. And indeed, 4 hours later, it's in a slightly different place, because this is 4 hours after that. So this is an atypical flush. It's people tell me that it's a different color. It's more a salmon pink than a red. But a typical flush is something that I've mentioned and relates to histamine release. So just a couple of statements then about neuroendocrine tumors and syndromes. So the neuroendocrine tumors of the syndromes, the most frequent syndrome is the carcinoid syndrome. It's most often associated with the small bowel. and most of those are, almost all of those that have carcinoid syndrome with small bowel also have tumors in their liver. People with lung tumors can also get it. People with pancreas tumors can rarely get it. The frequency of the syndromes, the frequency of the symptoms changes either with the site of the disease. So the small bowel has more syndrome than, say, the lung. It also changes with how much tumor there is. So a person may not start off with carcinoid syndrome or any of the other syndromes, but over the years can develop it because the tumors are getting bigger and therefore they're producing more of the hormones. So here's some data from the folks at MD Anderson. So in small bowel carcinoid tumors, 19% of them had carcinoid syndrome at diagnosis. But over time, up to 56% of them had carcinoid syndrome over time as the tumors were growing, more tumors in the liver. Here you see that lung carcinoid. Well, it only has carcinoid syndrome to start with in 8%, and it may be even lower than that, and it does rise over time, but it's nothing like the small bowel. And lung tumors have more carcinoid syndrome than they have Cushing's syndrome. In the pancreas, as I mentioned, pancreas has multiple possibilities. Now again, about 20% of people with pancreas neuroendocrine tumors will have some of these hormonal abnormalities at the start. Over time, these hormonal abnormalities can increase. They can also, in pancreas neuroendocrine tumor, they can morph over time. A person can start off with an insulin-producing tumor, and after therapy for that, they can come up with a glucagon-producing tumor or some other syndrome. So it becomes very fluid in the pancreatic neuroendocrine tumor. So the talk was supposed to be about the management, the hormonal management of tumors. So I'm going to talk about the types of therapies that are applicable to all of these syndromes. So carcinoid syndrome, Cushing's, ZE syndrome. So all of the syndromes, here are the therapies that will work for all of the syndromes. So you've seen some algorithms today. Forgive me for giving you yet another algorithm. But again, this is treatment protocol for patients with neuroendocrine tumors. They have options of surgery and somatostatin analog and liver-directed therapy that Dr. White talked about, PRRT that's been mentioned, some of the drug therapies that Dr. Mohammed and Dr. Ramirez talked about. So one thing I would say about all of these therapies in terms of the syndromes is that many of these therapies will take care of the syndromes, will take care of the symptoms. So a person who has a neuroendocrine tumor with tumors in the liver, if they get 70% or more of their liver tumor removed, they will go frequently from a state of having carcinoid syndrome to a state of not having carcinoid syndrome. So surgery is a good treatment for all of these syndromes, and that would be the same for a person with insulinoma and low blood sugar. If they had successful surgery, the symptoms go away. Somatostatin and lanreotide, we'll talk more about those guys. Liver-directed therapy, this was what Dr. White mentioned today, and this is a great therapy to turn around symptoms of the syndrome, symptoms of, say, carcinoid syndrome, because in people who have most of their tumor in the liver, producing hormones from the liver. So going into the liver and clotting off the blood vessels to the liver. These people frequently wake up the next morning without the flushing. They have pain and other issues, but they don't have the flushing and the diarrhea. It can be very quick, a little slower for the radioactive beads. But PRRT, again, PRRT has been shown to decrease syndromes, whether insulinoma or carcinoid syndrome. And indeed, I have many patients who have carcinoid syndrome. They come in for PRRT, and within a couple of weeks of their first PRRT, they know the difference. They can feel that the flushing and the diarrhea has really changed, even within that short period of time. Now, if we looked at a CT scan, there would be no shrinkage in tumors, but it can turn around symptoms related to the hormones rapidly. And of the drug therapies that you've heard about, CAPTEM, if it successfully shrinks tumors, significantly shrinks the bulk of tumors, it would be associated with less of the syndrome associated with the tumor. So, but I've been asked to talk about hormones. So let's talk a little bit about hormones, and I'm going to talk about using a hormone to control the hormones. And by this I mean that somatostatin analogs. So we've heard about somatostatin analogs before. Somatostatin analogs are your monthly injection octreotide, lanreotide for any of you that are on a monthly injection. Those are artificial forms of a hormone called somatostatin. You've had somatostatin in your body all your life. It was very important in the sort of the growth phase because it interacts with growth hormone. I'm still not clear, and I'm an expert on this. I'm still not clear what somatostatin does for the next sort of 40 or 50, 60 years, but it was very important in the growth and development. However, somatostatin is what we use to control many of these tumors, and it's via the somatostatin receptor. I'm going to really briefly do this because you've had this sort of a picture before. The tumor has docking sites, has proteins on the surface. If there's any somatostatin or somatostatin-like substances in the bloodstream, those somatostatin-like substances are going to come out of the bloodstream. They're going to attach directly to the tumor, and that's going to cause the tumor to stop the production of all the different hormones, and there are more than 24 different hormones that can come from neuroendocrine tumors, stop the production of all the hormones and decrease the growth rate. And you've seen other pictures today about what it does to the growth rate. So I'm going to show you some pictures about what octreotide or lanreotide does to the symptoms and the carcinoid syndrome and other syndromes. So this is number of stools per day, starting off at 6 in a person who's taking octreotide 100 to 300 micrograms 3 times a day, drops the symptoms within 4 weeks. You get the same benefit if you use the long-acting form of octreotide, which is sandostatin LAR. This is a very old study, 1999. This has been around for a long time. Lanreotide, I could show you the same sort of pictures with lanreotide, because again, it's just artificial somatostatin. It's going to attach to those to the tumor cells that have the receptor, and it's going to decrease the hormones. So urine 5-HIAA is the breakdown product of serotonin. So serotonin is made by the tumor. It breaks down to HIAA and comes out in the urine. Many of you will have had 24-hour urine collections. What they're measuring is 5-HIAA, so it's a variant on serotonin. But again, lanreotide drops those serotonin levels and lasts a long time. This is the better part of 2 years. But these medications, they're not just for carcinoid syndrome, so they will do the trick for any of the syndromes. And again, I put up this slide because it's a sort of a historical slide, and again, it's an Ohio slide or Ohio-related slide. So these are numbers from the first patient that was treated for a VIP-producing pancreatic neuroendocrine tumor. I told you that VIP causes horrendous diarrhea. And so this patient was treated at NIH. My mentor, the late Dr. Odorizio, was working at Ohio State University at that time, and it was in his lab that they measured all the VIP levels. So a couple of points about this graph. The VIP is in red, and you can see it comes down a little and then it drops down at 7 days. They increased the dose a little bit, and that VIP came right down. You can also see that there are a whole raft of other hormones on this list, stuff that we haven't even talked about. We talk a lot about serotonin, but there are other hormones there, and many of these hormones we still don't understand, which are the important ones beyond serotonin. And when this person's VIP came down at 7 days, their stool weight, their diarrhea drops down at that time. So a couple of things that I would just point out. I think there are opportunities to get even more from sandostatin or octreotide and lanreotide, and I think they're not well enough understood by many of the community oncologists, perhaps. This is a retrospective study, but now we have at least one prospective study looking at increasing doses of lanreotide. This is a study where they look back at over 200 patients who had been on octreotide or lanreotide at the usual FDA-approved doses, so 30 milligrams of sandostatin or 120 milligrams of lanreotide, and they had started developing more symptoms. Now, when those people were increased in their dose beyond the FDA-approved doses, so either going up to 40 milligrams or 60 milligrams of octreotide, or going to 240 milligrams of lanreotide, or changing it from a 4-weekly to a 3-weekly to a 2-weekly, what they found was that over the following year, 80% of people had improvement in their flushing and their diarrhea. So for symptom control, we don't have to stop at the FDA-approved dose. So if you're still having symptoms, there may be further improvement. So just on a practical level, octreotide and lanreotide, starting at the usual FDA-approved doses. Sometimes I start even at lower doses if it's just for symptom control with very little tumor. Increase the dose if there's insufficient control of the symptoms. This is one thing that I'd like to point out. Lanreotide and octreotide are there for two reasons. They're there, you have heard this morning, they're there to decrease the tumor growth. They're also there to decrease the symptoms. And both of those effects start at the somatostatin receptor. So my concern when people come in and tell me that, well, I really notice at the 3.5 week time point that I have a little more flushing and a little more diarrhea. So I really know when my next shot is coming up. And I ask them, well, would you like to go to 3 weekly? We could get rid of that symptom for you. And they say, it's no big deal. I take a little bit more Imodium, no big deal. Well, I think it might be a big deal. At least my personal sort of bias is that it's a big deal. And one issue is the symptoms, but symptoms are really good monitor of whether there's enough octreotide in the system. But you're taking that octreotide for another reason also. Slow down the tumors. My concern is that if there's not enough octreotide there or lanreotide there to take care of your symptoms, there may not be enough lanreotide there taking care of your tumor growth. And if you're taking something for tumor growth, take the optimal amount. Don't have it where there's 1 week in the month where you're not taking enough octreotide. So in those people, my personal practice is to talk about making it a 3-weekly medication or giving them some more of that to take care of the symptoms, but also in the back of my mind, I'm thinking that I may be doing a better job on the growth. We can increase the dose or we can decrease the interval. sometimes we get into the situation where we would like to go 3 weekly, but insurance doesn't want to cover it 3 weekly. That's a pretty common issue. And sometimes it's impossible to get over that hump. Frequently I have found that we can persuade insurance to cover self-injected octreotide as well as long-acting octreotide. And in that situation, I get people to start taking extra self-injected octreotide in those last few days or when they get breakthrough symptoms. And I start at 50 micrograms and might go up to as far as 200 micrograms. I like to prescribe the highly concentrated stuff. If this stuff comes in 200 micrograms per mil up to 1,000 micrograms per mil. People who use it tell me doesn't sting as much as taking a big volume of the dilute stuff. So try to get your doctor to write it 1,000 micrograms per mil. Remember, the gastrointestinal side effects, many people feel worse once they start on octreotide and senvastatin. And they feel worse because they're gassy, they're indigested, their stool is oily. All of those symptoms are related to pancreas enzymes. These agents decrease your pancreas digestion enzymes. Pancreas digestion enzymes are super easy to take. There are prescription type of pancreas enzymes. Creon is one of them. It's frequently poorly reimbursed. Our favorite and my favorite from learning from Dr. Odorizio has always been to put people on papaya extract tablet, which works very well. There are other over-the-counter digestion enzyme supplements. So if you've got any digestion issues related to your shots, those are, we can take care of those. Let's talk about, so those treatments, were treatments to take care of any of the syndromes, whether it's gastrin or insulin or VIP. I'm going to talk about some treatments for individual syndromes. So how would we decrease the carcinoid syndrome? One way is some people can identify the triggers to these symptoms, and if you can do that, you can either avoid it, or you can take some octreotide self-injected before the event. So you've got a birthday party, you would really like to have a glass of wine and eat whatever the heck you wanted to eat at your birthday party. 100 micrograms of octreotide might just take care of that for you for a whole 4 hours. And we've heard this morning about the really exciting sort of developments in tablet forms of octreotide. So hopefully these shots will go away, these self-injected shots, and you can sort of pop a pill and take care of carcinoid syndrome for a while. Dietary advice. Many people, again, can identify triggers within their diet. And so seeking dietary advice from a dietitian who knows something about carcinoid syndrome can be very helpful. So this comes from a text from one of the godfathers of neuroendocrine tumors, Dr. Warner, but also Leanne Burns is a dietitian who used to work at New Orleans. Leanne has authored a book with Tercera, one of the folks who are sponsoring the meeting, and many of my patients really like that diet book. Just pointing out certain foods that have a lot of tyramine, which causes secretion of these hormones with resultant production of symptoms. So, is there anything else we can do for the carcinoid syndrome? You know, there are a whole bunch of hormones that go into carcinoid syndrome. Serotonin is the biggest and most famous of them, but it ain't the only one. Serotonin probably causes at least 50% of the diarrhea in carcinoid syndrome. It doesn't actually cause much of the flushing in carcinoid syndrome. That's still a big unknown. Serotonin causes the heart valve damage. Serotonin is thought to cause the fibrosis in the belly. But there are ways of getting lower serotonin, and we've heard of one of these already. So quickly, this medication, Talotrostat, Zermelo, it is a medication that is specifically here to block serotonin. And I think you saw a version of this before. Protein gets broken down into amino acids, one of which is tryptophan. Tryptophan can either go to serotonin, or it can go to niacin, or it can be built up into protein. When there's carcinoid syndrome, lots of it goes down into serotonin, and that causes the diarrhea. Zermello blocks that enzyme, so stops it going into serotonin, so drops the serotonin level, and that causes a decrease in the diarrhea. You've seen that before. A couple of practical points about Zermello from my viewpoint. It is FDA approved to be used in addition to octreotide and lanreotide. It's better absorbed with food, especially fatty food, which most of you will be shying away from, but that's those are the data. Absorption is decreased by octreotide. So if you're somebody who is using self-injected shots of octreotide, don't take those before the Zermello. Do stop the Zermello if you get constipated. Side effects, I think most of the side effects of Zermello that I hear about are abdominal side effects. And many times, if those side effects start, it's a matter of starting slower. And this is not rocket science. If you got side effects from your blood pressure medication, you could start at a lower dose and move up. So it's a very important thing with Zermello is you may have to hang in there 8 to 10 weeks, 2 to 3 months before you see the full effect. So don't toss it in the bin, within the first 4 weeks if it doesn't seem to be doing anything. There are differences between the Zermello and the octreotide. Both of them decrease serotonin. Both of them decrease diarrhea. The octreotide decreases all the hormones. The Zermello does not. The octreotide decreases all the hormones, including the ones that cause flushing. There was a small percentage of people that had some benefit, but it's not a major anti-flush medication. There's a lot of work going on as to whether these agents could decrease serotonin and decrease the carcinoid heart disease. Ongoing work. Decreased tumor growth, well, you've seen that with the octreotide and lanreotide. Some work going on here, but I think not. Tablets, no for the octreotide, at least up to now, and yes for the other. A very important thing for you to remember, because once you're diagnosed with any tumor, after that, any symptom that you get, the first thing that comes to mind is, oh my God, my tumor is back. The pain in my toe, oh my God, it must be something to do with my tumor. The diarrhea, oh my God, it is the carcinoid syndrome. Yes and no. It's important to remember that not all diarrhea is carcinoid syndrome. So carcinoid tumors, you can treat those with the somatostatin analogs, the octreotide and lanreotide. You can treat those with Zermello and all of the other therapies that I've told you about. But if it's any of these other causes of diarrhea, those treatments are not the treatment. If it's because you've had your gallbladder removed and your bowel removed, cholestipol or cholestyramine is the thing you need. If it's because you've had these surgeries and now there's bacteria growing in your bowel, antibiotics. If it's because you've got a side effect of the lanreotide where it's decreased the pancreas enzymes, it's pancreas enzymes. If you've got diarrhea because the carcinoid syndrome has decreased your niacin, and you get a condition called pellagra, which is usually manifest by a reddish, scaly skin rash in sun-exposed areas, niacin is the treatment. And just because you've got carcinoid syndrome, and this was something that Marianne mentioned, she mentioned that you should still get your prostate and your breast exams done. Just because you got carcinoid syndrome doesn't mean that you can't have celiac disease, and I've diagnosed a number of people with other conditions. And again, it's no point in going up on the lanreotide if you've got some other cause. Other sort of things that crop up in case reports in journals, that can be something to try for difficult to control carcinoid syndrome. Before we had octreotide, what was used, apart from chemotherapy and surgery, what was used was a thing called cyproheptadine periactin. It's a very old antihistamine. It's a very, what would be called a dirty antihistamine. Dirty in that it blocks a lot of different things. It blocks serotonin effect to some extent. It blocks histamine effect. It's certainly not a non-drowsy antihistamine. It's a way drowsy antihistamine. But again, with slow dose, increments, some people find it helpful. Ondansetron, Zofran, you may have had this as your go-to anti-nausea medication. Turns out that has serotonin antagonist properties. One of the big side effects of using too much ondansetron is constipation, which might be helpful in carcinoid syndrome. Atypical carcinoid syndrome. So this goes back to that guy with the funny rash. And it tends to be in lung neuroendocrine tumor, gastric, stomach neuroendocrine tumor. Those are histamine, and some other symptoms that would go along with that is really itchy eyes with a flush, really itchy red eyes, really puffy red eyes with a flush, or itchy skin, itchy rash with a flush. Those are histamine, and adding in some non-drowsy antihistamine. I write Zyrtec here, but it could be Claritin or any of the non-drowsy antihistamines. And famotidine. Famotidine is Pepcid. That's a histamine 2 blocker, and that's a histamine 1 blocker. So you use both of them together. And you use big time doses of this Zyrtec. So Zyrtec is usually, a 1 a day for your seasonal allergies. Well, we're talking about 2 twice a day, or, big doses like that to block the histamine response. And then uncontrolled carcinoid syndrome, that's a reason to go back to all of those other treatments that you heard about this morning, because all of those treatments are going to have a benefit. What about non-carcinoid? I've talked a lot about carcinoid syndrome. What about all the other syndromes, the ZE syndrome and the insulinoma syndrome, etc.? Well, each of these different syndromes, apart from responding to octreotide and lanreotide, they have other medications that can be used for the symptoms. And gastrinoma, so I've told you that gastrinoma produces gastrin, produces high stomach acid, like way high stomach acid, drilling holes in your stomach acid. So treatment for this, apart from the previous treatments, is very high dose omeprazole, Nexium, Prilosec, those sort of medications, and very high doses, and high doses with high doses of Pepcid and another medication, sucralfate. Insulinoma, there are ways to block the effect of insulin. We have medications like diazoxide. We have slowly absorbed glucose to give to people. Everolimus is actually a treatment for neuroendocrine tumors of the pancreas, but it has a side effect, and one of its side effects is to put up the blood sugar, and it does that by decreasing the insulin. And we can sometimes take advantage of that in people who have insulin-producing tumors. Glucagonoma, vipoma is frequently intravenous fluids. I should just mention Cushing's syndrome. So this is where ACTH stimulates cortisol from the adrenal. So there are lots of things that block the cortisol production. There are a raft of 4 or 5 different blockers of cortisol production, and there are also blockers of cortisol effect. So one can control the symptoms of Cushing's syndrome just with these medications. Just one other call out for this, because it has been mentioned before, but it's something where I've changed my practice over the last couple of years because of an understanding of the importance of genetics, and particularly the importance. There's some very powerful studies now looking at the genetic contribution to pancreatic neuroendocrine tumors. So now 15 to 20%, and in some studies over 20% of people with pancreatic neuroendocrine tumors have a genetic disorder which can be transmitted generationally. And many of these people do not have a family history above them. They had no idea that they could have a genetic disorder, but it was only on testing that they found this. So there are a number of the genetics. It's important to understand the genetic syndromes, because genetic syndromes, they don't come as just a single tumor. They come with baggage. They come with other tumors. This is one gene that comes with tumors in the parathyroid that produce parathyroid hormone, that produces high calcium, pituitary, conditions, tumors, which produce various other hormonal abnormalities. The pancreas we've seen, MEN4, VHL. So there are more than a half a dozen different genes, and they all have other things associated with them. One other important thing about knowing the genetic syndromes is that some of them may have specific novel therapies. So in this VHL thing, there's a new drug for VHL is a genetic disorder that has kidney cancer associated with it. It has pheochromocytoma associated with it, pancreatic neuroendocrine tumors, and it has a number of other conditions, hemangioblastomas. So quite a complicated condition, but there's now an FDA-approved drug that's FDA-approved to take care of the kidney cancer in VHL, but it's under clinical trial to look at pancreatic neuroendocrine tumors in VHL and other genetic conditions. So genetics is important. I think the shout out there is consider genetic testing if you have a pancreatic neuroendocrine tumor. Okay. Thank you for your attention. Really impressed that it's 4 o'clock. You're still awake. I'll take a question in a moment. This is my group of my colleagues, some of whom you may have heard talks from Jim Howe, Dr. Chandra Sakaran. These are the people who make the Iowa group tick. Usually when I'm doing a teaching session for students, I'm asked to come up with some multiple choice questions. And actually, Bob, one of the first things that you said this morning when you were by the slides is, there's going to be a question session on this. So I was going to ask people to list 6 hormones that come from neuroendocrine tumors. I'm not sure that I could put this together at 4 o'clock. So this is a trick question. What's the best seat in the house at an Iowa football game? That's very good. That's very good. So it's a trick question for a couple of reasons, because if you're an Ohio State fan, it really doesn't matter which seat you've got in the Iowa Stadium, because you're going to be the only one who's going to be hooting and hollering and standing up, because all the Iowa people will be glumly sitting down or leaving early. That's how it is. Same for the Michigan folks here. That's how it is. Any seat in the house. And you know, I'm Irish. Football to me is a game that's played with a spherical ball with your feet. So, you know, I've never really got into American football as it is. But there is at least, and Iowa don't win all that often, so that's not very heartwarming. But there is at least one heartwarming part of the Iowa games. So the best seat in the stadium is actually not in the stadium at all. It's in the top floor of the Children's Hospital. Now, it's, you know, I've been in Iowa for 20 years. I do not know why some university planner decided to put an 80,000 seat stadium 50 feet away from a 1,000-bed hospital. Do not get a heart attack on 6 Saturdays in Iowa, because you're out of luck. You're flying back to Michigan, frankly. But so many of you know that at the end of the first quarter, everybody, teams, officials, etc., turn around and give a big shout out to the kids, and that for me is heartwarming American football story. So thank you for your attention.